Hello, everyone. I'm Costas Marmayolis. I'm from the University of South Florida, Tampa General in Tampa.
Good morning. I am Kechi Ijama at The Ohio State University in Columbus, Ohio.
I take issue at her saying the Ohio State. I'm from the University of Michigan, but I'm actually work here in Denver, Kaiser Permanente and Intermountain Health.
So just some housekeeping rules. We'll try to keep the presentations to 5 minutes and do a lot of interaction right after the presentation if possible. So why don't we start with our first presentation, refractory left main coronary vasospasm in a male patient undergoing gender transition. Dr. Ranganathan.
Good morning, everyone, and thanks for the opportunity to present. So this is a patient, 56-year-old, born as male, presented to our emergency room with persistent ICD shocks for VT storm. And going back to the past medical history, a month before, he was hospitalized at an outside hospital for VT arrest. At that time, a left heart catheterization showed that there was severe vasospasm in the left main, which was treated with 600 microgram of intracoronary nitroglycerin and had normal biventricular function. So at the time started on vasodilators, and an ICD was placed for secondary prevention. Going further back into the history, for the last 10 years, this person has been getting a stress test followed by her left heart catheterization every year because of persistent chest pain. At least the last 4 years, the symptoms are getting worse to a point it's happening every few weeks, responding with a sublingual nitro. And on this left heart catheterization, they found that there is a proximal RCA stenosis 50%, which is by IFR and by IVUS, it wasn't significant. But in the last 3 years, they said, okay, the chest pain is getting worse, so we're going to do a PCI. But the patient is having persistent symptoms despite PCI. And more into the medical history, he's been using estradiol transdermal patch for the last 3-4 years, which correlates with the time of increasing frequency of angina, but hasn't told anyone, and not his or their physicians as well. And active tobacco use, which has been going on for the last 20-30 years. So while we brought him to the cath lab, he had pulseless electrical activity and cardiac arrest requiring CPR, emergent cannulation for VA ECMO and Impella CP. But within 30-40 minutes, pulsatility comes back and there is normal biventricular function. This time the coronary angiogram was normal. Patient was taken back to the cardiac ICU where there were intermittent episodes of ST elevation on the monitor. Sometimes there will be loss of pulsatility, although now the patient's on VA ECMO. So this is the first time we actually started cardism for a cardiogenic shock due to vasospasm. Cardism, nitroglycerin. Hemodynamic is stable for 48 hours, so we thought, okay, now we have introduced vasodilators, maybe we can wean the ECMO off. So the ECMO Impella was decannulated in the operating room while they were shifting the patient from the OR table to the stretcher. There was hypotension, so anesthesiologist gave IV phenylephrine, which resulted in ST elevation on the monitor and hypotension. But we were able to stabilize at that time just with vasopressors and inotrope. But within the 24 hours, early morning, again, same thing happened. PE arrest, ST elevation on the monitor, loss of pulsatility on the arterial line, had to be emergently cannulated for VA ECMO again. And this was EKG done during one of those episodes where you could see QRS widening, left bundle branch block. So we had a heart team approach and said, okay, this person has recurrent left main coronary spasm. We tried to manage with MCS and medical therapy. So tobacco is a known contributor, but it's hormone therapy an additional contributor to this. So we decided to proceed with a coronary angiogram. And here you can see we used an R2P sheath because we were worried about radial vasospasm while doing the procedure, and the femoral arteries are cannulated for ECMO and Impella. And you could see as we were engaging the left coronary, diffuse spasm. And we tried to wire, this is after nitroglycerin, and we wired the coronary. We just wanted to wire some vessel. And then we tried to do an IVUS. And in the IVUS, we did not see any atherosclerotic disease in the left main or even in the proximal LAD. So we measured it as a 40 millimeter vessel, performed direct stenting. And this is the post-PCI result. At this point, we decided, okay, let's try and give IV phenylephrine 40 and 80 microgram, and there was no recurrence of vasospasm. And I have an IVUS picture. Now to go back. But the key learning points, and the stent was well opposed and well expanded. So the key learning points I thought in this case was 3. Number 1, pathophysiology. We usually think about the traditional risk factors in patients with smoking or diabetes, hypertension, causing vasospasm. And in this patient, using estrogen in a person who was born male and trying to change the gender and using estrogen increases the risk of cardiovascular events. A recent meta-analysis published in the European Journal showed that transgender women are at higher risk of developing cardiovascular incidents compared to the cisgender. And even though this is a new result, we know this from 1970s. There was a study done called the Coronary Drug Project where they gave estrogen, high-dose estrogen to men, and men dropped dead. So we know that estrogen in high doses can cause coronary events. And the second thing from the technical aspect, left main PCI for coronary vasospasm. Usually coronary vasospasm we try to deal with medical therapy, but since it's involved the main artery of the heart and the patient already died more than once, we proceeded with the PCI. And third, whenever we talk about MCS use, we think about Impella for high-risk PCI, or even in shock, acute MI shock, that's our first go-to device. But in this person, left main coronary spasm almost caused 2 things. 1, an electrical instability, and also a pump failure causing biventricular dysfunction. So I thought this was a unique case to demonstrate that. And thanks for the opportunity.
This is a fantastic case. I have to congratulate you on taking the risk to actually stenting this, and I think it was a good bridge to at least allow some perfusion in the left main. I have to say that there are some other techniques that may be considered in particular VT storm patients, and this is sympathectomy. And I have done a couple of those with stellate ganglion ablation, which is a cryoablation of the stellate ganglion. It's less invasive, but it could be also done through VATS with thoracic surgery, so something else to be considered in this particular type of VT storm patients with spasm.
That's a valid point. I didn't include this here. Electrophysiologists actually gave lidocaine. They did the stellate ganglion blockade, not did the sympathectomy for 48 hours. Not sure if actually that worked and gave us that 48 hours of, kind of sense of the patient was stable.
Our panelists.
Great case, and congratulations for having the courage to put a stent, because there is always a theoretical concern that the next time patient spasms, that he may dissect the LAD and drop dead. So in general, we don't, at least our group, we don't have the courage to do that in people who have evidence of such aggressive vasospasm. But we have a couple of similar cases in the last 10 years, and we went through the same process. The sympathectomy, the surgical sympathectomy has worked well. For the 2 cases that I remember that the surgeon did the surgical sympathectomy, those patients had much milder events, and just with chronic calcium blockers and long-acting nitrates, they continue to do well. But congratulations, it's a great approach, and if this patient does well in the long run, maybe this is the answer. I don't know what you think.
So we're following up the patient for 2 months, 2-3 months off hormonal therapy, but still smoking a cigarette here and there. 1 or 2 episodes of chest pain per month, resolved with sublingual nitro. But for the last month, back to hormonal therapy, now having chest pain every 2 days, 3 days. So it's a challenge. But I think something to consider for future, the sympathectomy would be a long-term solution.
Any other comments from the audience or the panelists? Okay, thank you.
Thank you.
And I'm going to introduce the next speaker. All roads lead to RCA, multi-approach in CTO PCI, Dr. Ahmed Kamal.
Good morning. Okay. My case today is all roads lead to RCA multi-approach in CTO PCI. Our case today is a 56-year-old gentleman. He's known hypertensive and smoker. He presented to his typical chest pain, Canadian class 3. ECG showed no significant ST wave changes, and the echo showed normal LV dimensions, ejection fraction 54%, no regional motion abnormalities, and no significant valvular disease. The patient underwent previous coronary angiography 4 months ago, which we'll show now. Here, the left main was normal. The LCX was normal with retrograde collaterals to the RCA, as shown here. The Remes branch was normal. The LAD showed mid-segment borderline lesion with retrograde septal collaterals to the PDA. The first diagonal branch shows proximal significant lesion. The RCA shows paraostial CTO with faint antegrade flow. This patient had the failed trial of PCI to CTO in the other hospital, as shown here. Our clinical challenge was that we have a very proximal RCA CTO with previous failed trial of PCI. There was well-developed retrograde collaterals from the LAD and LCX. The mid-segment LAD had an atherosclerotic plaque causing 60–70% luminant stenosis, which may affect the retrograde approach to the septal perforators. The retrograde collaterals from the LCX are epicardial and hardly tortuous. We plan to have a dual axis, right femoral artery for the antegrade approach and right radial for the retrograde approach. Amplets left 1.7 French guiding catheter to engage the RCA and EPU 3.56 French guiding catheter to engage the left main with a run-through floppy wire in the LAD. We do a dual injection to reassess the retrograde collaterals to the RCA from the LAD and LCX and to know the length of occlusion. As we can see here, the collaterals are mainly from the LCX with faint collaterals from septal perforator from the LAD. The length of occlusion was around 25 millimeters. We had trial of antegrade approach using Mamba microcatheter over the Samurai wire. We do wire escalation with Judo 6 wire, but it passed subintimal. We then do parallel wire technique using recross microcatheter, keeping the Judo 6 wire in the subintimal space and using the Gaia 3rd wire to enter the true lumen. Repeated attempt to pass to the true lumen failed, unfortunately. After many trials, the wire appears to be in RV branch. However, the microcatheter injection showed we are in subintimal space inside the RV branch, so antegrade approach was stopped. Now we have to shift to the retrograde approach using septal collaterals from the LAD, using surfing technique by cyan black wire and deep injection from the Caraval microcatheter, but unfortunately, we cannot connect to the RCA. Now we are left with the only retrograde collateral from the LCX, which are long, epicardial, hardly tortuous, and the LCX itself is tortuous and has an acute bend at its proximal segment. We use Samurai wire over Caraval microcatheter, which failed to cross the acute bend in the proximal LCX, so exchange with cyan black wire that successfully crossed this segment, and then the microcatheter advanced over the wire, but deep injection seems we are in small branch. Many trials were done to try to reach the collateral as a distal LCX, but the wire failed to catch this collateral. Finally, the cyan black wire passed through a highly tortuous, long epicardial collateral arising just after the acute bend of the LCX. The wire failed to advance more through this epicardial collateral, so careful tip injection was done, but that confirmed we are in the true track. And after many manipulations with the wire, it passed a segment of the collateral, but goes into an abnormal track, as we can show. Finally, our wire succeeded to pass through this highly tortuous band in the collateral and reached mid-RCA, then to the distal RCA confirmed by the retrograde injection, and the microcatheter was advanced carefully over the wire till it reached the mid-RCA, then the tip injection confirmed we are in true lumen. Antegrade injection from Amplitz 1 catheter showed large dissection and hematoma extending into the RV branch. We tried to cross the antegrade from subintimal space to true lumen using the gladius wire over the recross microcatheter, but failed. Then we used the Fielder FC wire of a Mamba microcatheter to try to puncture the CTO proximal cap, but failed, then escalated to Gladius wire, then Hornet 14. But unfortunately, it passed into a false lumen distally. And finally, our Conquest Pro 12 wire managed to reach true lumen. The Mamba microcatheter advanced over the wire and tip injection confirmed on true lumen. Then retrograde microcatheter and wire are withdrawn, and contralateral injection confirmed no complication in the retrograde collateral. Pre-dilatation using Maverick balloon 2 times 30 millimeter. The BL branch is still occluded and receives retrograde collaterals. So we have cyan black wire over the recross microcatheter and used to pass through the BL branch confirmed by the retrograde injection. We do pre-dilatation to the BL branch using the Maverick balloon 2.5 times 30 millimeter, then kissing balloons with Maverick balloon 2 times 30 millimeter in the PDA. We do stenting of the distal RCA to BL branch using 2.5 38 millimeter, then to the mid RCA using 3.5 times 38 millimeter drug-eluting balloon, and finally to the proximal RCA using 4 times 38 millimeter drug-eluting stent. This was our final angiographic result. With the disappearance of the retrograde collaterals. Our key learning points, careful planning and having strategy is crucial in CTO PCI. You must have the ability and tools to shift from one approach to another at any time during the procedure. Teamwork is very important in lengthy and complicated procedures like CTO. Thank you.
Very nice case. You know, these epicardial collaterals are tortuous. They're very risky, right? So I'm sure you had a plan, you know, for bailout and what you would do if you perforated or lost that collateral.
We can use coils, or we can use graft stent in the LCX to just close this epicardial collateral.
Probably that would result in a lot of inferior ischemia as well, right? Perhaps.
Perhaps, maybe.
Perhaps. Okay. The other thing is the antegrade injections. You know, what are your thoughts about that? You know, repetitive antegrade injections. I try to avoid that on these kind of cases because you can get a dissection that actually goes up in the aorta.
We try to minimize these antegrade injections. Yes.
Great case. Curious on cross-boss Stingray as a antegrade approach, certainly before using the epicardial collateral. Was that considered? And then number two is some of this amazing display of using different modalities. I think that's the key, not to bang your head and use one technique. So you went antegrade, retrograde, subintimal. So congratulations. But what was your fluoroscopy, your radiation dose, and how long did that procedure take?
Okay. First, we don't have cross-boss or Stingray in our cath lab at that time, so we cannot use it. We took around 3 hours in this procedure. We used a lower dose protocol in our cath lab. I don't remember exactly the radiation dose, but I think it is around 4,000, 5,000.
Congratulations. It
Thank
takes
you.
a lot of courage to use an epicardial collateral. I also think it was a great demonstration of the hybrid approach, which is what we all advocate for, starting from something that is lower risk, and then which was your antegrade approach, and then proceeding to retrograde, and then finally epicardial. So very nice work.
Thank you.
I agree here. I'm not a CTO operator, but I will say that the way you outlined your case presentation was very clear and easy for people to follow and understand your decision-making points. So very nicely done.
Thank you.
All right, thank you. Our next talk is by Dr. Elrayes. It's 3 in 1.
Good morning. I am thrilled to be here in CVI 2024. My case is not one communication, but three communication, a cocktail of communication. My case disclosure, I have no disclosure, but I hope I have after this presentation. My presentation, my case is 65-year-old female with recurrent angina with positive stress, with history of PCI to LED diagonal and RCA 3 years ago. I did the coronary angiography, diagnostic. There is ISR of mid-LED stent. The bifurcation technique, I couldn't identify which technique, but maybe V-stenting. So my plan is to switch to 7-pharynged system, a strong guide like EBU 3.57 pharynge with TCAP preloading, then wiring both branches LED and diagonal, guided with clear stent, because in my cath lab I have no imaging. Then according to the result, either DCB or drug-eluting stent. The angiography was 7-pharynged catheter. The clear stent, there is ostial stenosis of mid-LED stent. Then I did balloon dilatation, then kissing with the diagonal stent. Then escalate my balloon to a bigger balloon, 3.5 by 20 in C. This is the result after dilatation. So you can see in clear stent, there is overstretching of the stent. When you have a suspicion, you should leave the balloon in the guiding. So I get this. Ellis type 3 perforation. But fortunately, I have the balloon within the guiding. So what to do? First is to inflate the balloon proximal or at the site of perforation. So you follow the algorithm. You have to think, you have to accept, you have to avoid denial, bargaining, or anger. So the first step in the algorithm is universal. And between universal and type of specific treatment, period of thinking, period of preparation. So I inflate the balloon, call for help, call for echo for another colleague. Then prepare echo, precursor set, and fluid vasopressor. Then you go to the first part of the algorithm is large vessel perforation. When there is persistent extravasation, I will go to covered stent. While I am tamponading the artery, I get this. What to do? The first thing to do is to deflate the balloon, then to go DC shock, defibrillator. So the second nightmare, resolution with balloon deflation and shock. So I immediately go for graft master stent 3.5/19. I position it guided with clear stent in the overstretched area. And this is the final result. What to do next? Is this final? No. There is missing view. It's partial view, not complete view. So I got this view. Distal wire perforation. You have to accept and think. Then go to the second part of the algorithm. Is balloon tamponade, then think. First, embolization if persist extravasation, or cover stent if it is overside branch. So I did short balloon tamponade, not prolonged, like in the previous perforation. So there is persistent distal extravasation with no available microcatheter. What to do? Period of thinking while stabilizing the patient. I thought of two options. First is to deliver balloon segment or fragment by cutting the distal part of the balloon, or use a thrombosuction catheter as a microcatheter to deliver fat or thrombus after dipping it in a contrast. The key elements in delivering a balloon fragment is you should have good support, open way, no tortuosity, no stenosis. So as you not to miss the balloon segment within left main or proximal LED. And the artery, the wire in a distal stable position. So I deliver the balloon, I put the balloon fragment over the wire, then another balloon, small balloon, so as to cross. So I freeze the wire, withdraw the wire. So the balloon fragment settled in the distal artery. Then waited for few minutes. Until now, I didn't give protamine because there is risk of stent thrombosis, 2-3 layers of stent. So this is the final angio. So I can recap my case in the 3 circle of CVI: C, coronary perforation; V, ventricular fibrillation; I, innovation for a method. K, learning for operator and the team. Strong support is of utmost importance. Avoid overstretching. Imaging, if available, will reliably guide PCI. Always leave the balloon within the guiding if you have suspicion. Communication, budget communication, 3-in-1, you have to follow the algorithm. Short, brief, intermittent balloon tamonade, or use, if available, perfusion balloon like ringer or microcaster to mitigate ischemia and arrhythmia. Longer cine with banning and without collimation, always open the shutter to see the complete view, not the partial view. Balloon fragment is a simple, economic-ish rescue for distal web perforation. Thank you.
That was a remarkable case. I think it's a wonderful result, and I have to commend you for your innovation.
Agreed. Thanks for sharing those. I think those are amazing. I wish I could show that to many of our fellows. When you think about this case in retrospect, what do you think led to the kind of the initial insult, the overstretching of that first stent?
Basically, if I have IAVOS, I will go in, I will do communication like this. But unfortunately, it can occur even with the IVs. If I oversize the balloon, oversize the stent, or overinflate the balloon or the stent.
Great case. I've never seen that before, so I always love to learn new techniques. But in most cath labs, we do have microcatheters, we do have coils and things like that, and you could also inject fat, like you had suggested.
Yes.
I see you're from Egypt. Welcome. Do you not have a complications cart there that you can use for complications like these?
Could you?
In terms of, do you not have coils, or do you not have access to microcatheters?
I don't have.
It's Egypt. I'd hope you have papyrus stents right now.
No, once again, I echo my colleagues here. Great case and welcome from Egypt. And I think this also shows that even for our colleagues who are in third world countries who may not have the things that we are blessed with here in the United States, that you can be innovative. So very well done. And thank you for sharing this case with us.
Thank you.
Had you used that balloon technique before?
No, first time.
Wow, okay.
I always watch the distal wire.
Where did that come from? Is that something you had read about, or you?
Yeah, some cases, but during the communication, brainstorming brings this to my mind.
How do you cut that balloon? Just with a scalpel,
yes,
or?
Yes, with a scissor. Yes, I cut the distal part, then advance, then smaller balloon next to it.
Courtney, could you make sure we have scissors in the lab, please?
One other thing you can do is you can put an over-the-wire balloon distally,
Yes.
and you can take a piece of blood from the patient,
Okay.
let it clot.
I don't have over-the-wire balloon. I only have a thrombosuction caster, so I can use it for this purpose.
I see.
The other thing is to use a little bit of thrombin. We've done a small thrombin
Thrombus,
injection,
yes,
and it's
thrombin.
worked really well.
Or you can take some blood, leave it to clot a little bit, leave it, and then inject it through
Yes.
the over-the-wire balloon. But yeah, Great
Agree.
case.
Thank you.
Congratulations.
I have one comment. I'd like to congratulate my colleague for this case. Actually, there is some case series published from Mohamed Alam in Newcastle about using this technique for distal wire cleft. So there is some cases like this. Either to the point of an economic use of equipment, or when we don't have access for weights.
Okay.
And it's used as well in locking anything. We call it condom technique to lock a distal flow either through a graft to a native coronary artery.
Thank you.
Thank you.
I would like to invite the next speaker, Dr. Mahmoud, who is going to talk to you about to us about "This is not the whole story. My abdomen hurts me." He's not here.
Is he here?
Is he here? Is he here? All right, let's move on then to the one after. Dr. George Shenoda, please. Never celebrate so early. Welcome.
Hi, I'm Dr. George Shenoda from Sohag, Egypt. My case title today is Never Celebrate So Early. So I have no disclosure. My patient is a 76 years old male presenting by angina class 3. His history of previous unsuccessful trial to CTO RCA 1 month ago. ECG showed T-wave inversion in lead 2-3 and AVF. And his echo showed ejection fraction 50%, hypokinetic posterior wall. This coronary angio. So we use bifemoral sheath, Amplis left guiding for RCA and XP 3.5 for left main. And as you can appreciate here, there is a long segment CTO RCA in mid segment. And we have a good collateral from LED. So we calculate GC2O score as 2, one for the previous trial, and the other one for the length of the lesion. So our strategy, we started with anti-grade wire escalation. We used pilot 150 wire and microcaster crosshair XS. And it was easy job as we thought, and the wire passed the lesion easily, and we thought we finished the job. And we celebrated like Charleston here. But, okay, microcaster failed to pass the lesion. So we tried to do PTCA where the microcaster failed to cross. But unfortunately, we lost the distal wire position, so unfortunately the gone is cancelled, it's offside. So we tried other techniques. This is where we tried to do PTCA, where the microcaster failed to cross. And that's after we lost the distal wire position. So we shifted to parallel wire techniques, and we failed, so we tried to knuckle, and this why I tried knuckling. We then failed to knuckle, so changing microcaster and wires, but no progress also. Another wire, Gladys MG to knuckle. A very large knuckle here. Different wires, also we failed to reach the distal artery. So we changed our strategy to retrograde. Using crosshair, microcaster, and then Carvel, and Sion black wire, and different wires, we finally reached distal RCA. And with assisting with guide liner, we succeed to do reverse cut. So troubleshooting started. The RG3 wire failed to move forward, and there was severe resistance while trying to push it until it was stuck distally in this RG3 in the Amplis left. and this stuck where it's stuck in the distal out. So how we can solve this problem? While we're trying to manipulate the RG3 wire, we lost also the antegrade gear, and the RG3 still here in the descending aorta. So we tried to snare it. While we are doing that, the patient had severe chest pain and collapsed. And this is why we're trying to snare the RG3. But finally, we succeed to externalize the RG3 with the snare, and we managed to cannulate RCA over the RG3, and we did PCI to RCA by 3 stents, as you can appreciate here. So this is our final result. So acute complication of CTO PCI, this is what happened with us: entrapment of guide wire and management, equipment entrapment or loss, guide wire, the management like we did snaring. My take-home message: chronic total occlusion intervention are among the most complex procedures within the panorama of PCI. Awareness of potential complication, adequate procedural planning in order to avoid them, and prompt recognition and management should be occur at the cornerstone of successful CTO program. Complication can be acute or late after the procedure and can be cardiac or non-cardiac. Acute cardiac complication can occur directly at the coronary artery level or can have other strictly non-coronary manifestations such as hypotension, myocardial infarction, arrhythmia, or tamponade. The operator should be aware of potential complication and should plan the procedure in order to minimize the risk occurrence and promptly respond to them if they do arise. PCI of the principal acute coronary complication, including vessel closure, perforation, and equipment entrapment or loss, is feasible most of the times, and the operator should be aware of the key techniques successfully be allowed. And lastly, this sorry. This okay.
I think these are one of the most challenging situations when we have a gear entrapment. So congratulations on salvaging the patient. Can you tell us what do you think caused the hemodynamic collapse when you were snaring, and what were the thoughts going through your mind?
Because we closing the retrograde by the retrograde gear, and we have a good flow in the antegrade RC. I think this is a problem. Yeah. And the patient has severe chest pain from, I think, from the retrograde and the antegrade, and maybe have something like, from the pain, something like, yes, vasovagal.
Yeah, so it is very important to have a control angiogram of your retrograde gear for the donor vessel, because at this point you may have double jeopardy. You might have dissected the left main as you were trying to snare the externalization wire.
Sure, we did something like that, okay.
That is a very impressive case. Thanks for presenting. I'm always interested, I'm also not a high volume CTO person. I'm always interested in folks' perspectives on when to pause mid-case. I know there's a lot of dynamics that go into that, both economic and
yes, we use a lot of wires and microcasters, yes.
Talk to me about how you decided to go retrograde when your antegrade techniques failed versus bring the person back a different time.
It was the second time because he has a failed trial, so I didn't think he will come back again. So we tried all the algorithm of antegrade and we failed, and then we shift to retrograde, and we have a good septal connection, so it was a good option.
Great case.
Thank you.
It's very frustrating because you lost wire position the first time, and I think it's not infrequent that we lose some of the fundamentals about making sure our guides are well seated, and in trying to cross microcatheters, we can kick everything out. So that's very frustrating. Number two, what's frustrating is you were successful retrograde, and you were just merely trying to externalize the RG3, and it wouldn't it got stuck.
Yes.
And
It
that
got
led,
stuck 2 times, first
Right.
in AL and distal in the aortas.
and that's frustrating too, because now that led to you having to snare. And so I do think, you know, it's very important for us to remember that the tolerance of these microcatheters is not really designed to do all of this septal crossing. And that in doing so, when you do a lot of exchanges, you got to really make sure that you try and flush these microcatheters or even exchange them. Because at some point with the exchanges, the wires just can get stuck in there. And I think maybe that's what you face. It's hard to pull the microcatheter out to exchange it because you've, you know, made so much progress. But I do think one of the take-home points for me is not to get in a situation where your RG3 gets stuck.
Okay. We changed the microcatheter twice. We were doing the retrograde. We used the crosshair, and then we used Carvel. So already changed it. But the time of the procedure, we spent about 3 hours. So the microcatheter may be exhausted. Also, the wires may be exhausted. I think so. This is the cause.
Is that why you think the RG3 got stuck? Just
maybe, and I think the RG struck. It was in many literature. It happens to a lot of operators, and they also use a snare to resolve this problem.
So when you when your RG3 was stuck, did you first snare it and then exchange the catheter?
No.
Because
We tried, when it's stuck in distal aorta, we tried to push it, okay? And then we lost the anti-grade gear, so we had to snare it without catheter. It was floating in the descending
But it
aorta.
was moving, right?
Yes.
I mean, every time that it has happened to us when we get stuck, usually it's stuck because the catheter, we overturned it, or maybe the fellow left a little bit of contrast in the catheter, and then we cannot push, we cannot pull, and we have to bring it all back. So it's really impressive that you couldn't advance it, but then you were able to exchange the catheter. So it was, I tried to understand how did this happen. So I thought maybe that you snared it, so you stabilized it in the aorta, and then you exchange the catheter.
No, we snared it outside, and then we put the catheter and the 0.35.
So you externalize first, and then you...
Yes, we snared and externalize it, and then we put the anti-grade gear over it.
Yeah.
All right, thank you very much.
Thank you.
Our next speaker is Dr. Chirag Buch. His talk is Size Matters, Use of a Peripheral Arterial Stent in a Severely Ectatic Right Coronary Artery.
Perfect. Good morning, guys. I'm Chirag Buch. I'm one of the cardiology fellows at UT Health San Antonio. No disclosures. So here's our case presentation. We have a 60-year-old male who presented with severe chest pressure. Was taken emergently to the cath lab due to findings of high-risk and STEMI-type features. Initial troponin was 6,700. Repeat one was 16,000. He had biphasic T-wave changes and inferior leads and kind of the tombstoning appearance in the ST segments. Pertinent cardiovascular history, he had hypertension and hyperlipidemia, and he had a cath done 2 years ago which showed an ectatic right coronary artery, but otherwise was non-obstructive coronary disease. So here's the angiogram 2 years ago. As you can see, the RCA was pretty ectatic and otherwise non-obstructive coronary disease. Here's his echo when we got when he came into the ER. You can see posterior wall hypokinesis. So here's his coronary angiogram when we went to the cath lab. RCA with severe ectasia, which was known, but now he has a 99% thrombotic lesion in the proximal RCA with non-obstructive left-sided system. So here's our clinical challenge. Patient has a very large diameter RCA. It's very ectatic. Our estimate was 7 to 8 millimeters in diameter, and now with an acute thrombotic lesion. So this slide is to highlight the coronary balloons and stents. Despite the overexpansion, the largest diameter that we have is 6 millimeters. So what do we do? So initially we had a 6 French sheath that we had used, so we upsized the 6 French to an 8 French sheath. We used an 8 French AL 0.75 guide for the RCA. We also placed a venous sheath just for bailout meds and or pacing if necessary with a 5 French right common femoral vein. He was already on heparin. We started cangrelor infusion. RCA was wired using a BMW wire. And given the suggestion of a thrombus, we used penumbra. We did a couple of passes with the penumbra before that. Then we IVISed, and we were able to confirm the diameter of about 8.7 millimeters of the distal diameter of the vessel. So the BMW wire was then swapped for an 0114 mailman wire. A VisiPro stent was attempted. We used 8 by 27 millimeter VisiPro stent, but there was poor support. So the mailman wire was then exchanged for a 018 SV5 wire over the catheter. Then we did use the VisiPro stent and deployed at 12 atmospheres. There was immediate ST elevations, poor flow, so we were concerned for no reflow. We injected intracoronary nitroprusside, nicardipine, adenosine, with immediate improvement and restoration of the blood flow. So here's the IVIS images. The first figure is showing the ectatic RCA with 99% thrombotic lesion. The bottom is going to be the final angiogram with an 8 by 27 millimeter VisiPro peripheral stent and IVIS with good apposition. So follow-up, immediate follow-up outcomes were favorable. The patient experienced relief of chest pain, no immediate complications except for the intraprocedural no reflow, but no stent thrombosis or dissection. He was followed up a week in clinic. He reported cough, so he was switched from Berlin to Plavix, otherwise was doing well. So the key learning takeaway points that I had from this case were, coronary ectasia refers to abnormal dilatation associated with blood flow disturbances, which can lead to high thrombus burden in that area. There are no guidelines per se for PCI and stenotic ectatic coronary disease. Dilatation may lead to difficulty in determining the stent size, type, and the ability to complete full expansion at that lesion. Complications include stent migration, incomplete expansion, and the risk of restenosis, thrombosis, distal embolization, no reflow, and shunt formation. So in selected patients, peripheral equipment such as wires, balloons, stents can be utilized if coronary devices are not large enough. Thank you for your time.
Since this was my case, I'll pass it along here.
Well, congratulations. I find these one of the most challenging. Ectatic vessels, very difficult to get rid of clot, and no reflow is a big risk there. I think the important message here is IVIS really helped you, because what often happens is people would just size based on the angiogram and sometimes undersize the stent, and then we run into trouble with stent fractures and overexpansion. I just want to ask you about the medical management of these patients afterwards. I know some of us put them on DOACs or anticoagulant. Was that something you would have considered in this particular case?
Yeah, so we started them on DAPT, and we were going to plan for a longer duration of DAPT.
Great case. I'd actually be interested to use short DAPT in this person because the stent is so huge. Like Dr. Toleva, think about anticoagulants at some level. Every place in the country is set up differently with respect to peripheral interventions, and I don't know if you all do peripheral interventions yourself. Okay, so you have your equipment right there, right available. In some places, at our shop, you would have to run down to IR to get some of that stuff. Or the OR, exactly.
I mean, would you have put a 5.0 Megatron or something in, and then just found a big balloon? And I mean, what would you guys have done in this case?
I think I would have done very similar to what you did. I loved the use of IVIS. I think we have a lot of whether it's a steel core wire, we have some peripheral wires in the lab that we use for various and sundry things. And then once we got flow back in the vessel, I think I would have had someone run down to IR and get me a pile of stents and gone from there.
I mean, we put an 018 wire down. I had the 035 ready, the J that comes with the exchange J. I was going to put a 035J down the right next, so I was kind of I was a little bit crazed. I don't know.
No, it's very interesting that you put an 018 wire. I was always thinking that the 018 may have a much greater role in the CTOs and in the coronary. Have you done that before? Is the first time you put a 018?
This was the first time, yeah.
And it would be interesting to see, it was a balloon expandable stent. It would be interesting to see if you could put like a self-expanding one, you know?
I think deliverability would be too tough with the self-expanding. The other thing you can do is put two 014s down and try to put a peripheral balloon over that. So you could put, you know, two mailmans or whatever, or two, you know, whatever wires.
Yeah, I think we've done this with actually drug-coated balloon, completely off-label from the peripheral, and we've used two 014 balloons.
I used a Lutonix 4040 Monday in the left main, so maybe I have some bad habits. I don't know. Well, thank you.
I was just going to mention, it looks like we're on time. We're okay with time, Anand?
We lost our timer, so we're on the cuff. We're just going.
I was just going to say for, you know, cath lab staff, the ID and OD of products is what it is, and it's true. And so as long as you know your product sizes and what they're compatible with, either guide or sheath, then you're good to go. And, you know, this is a great way using a peripheral solution to a ectatic coronary. Now, if you're a coronary operator without those peripheral skills, you just call your peripheral colleague who has some, you know, experience using those type of devices. And again, if you have the appropriate size devices, they should work. And I've done that before, putting in a Express LD, SD actually, into an ectatic right. The other option is if you only have the jumbo stents, all you're going to do is disarticulate the stent in the terms of you're going to break some of the joints, but the majority of the radial strength will still be intact. So you could take a 5.0 to 8, you would just break the stent, but the intact radial strength portions would still be there. So if that was your only option and you didn't have that peripheral equipment in that scenario, that's a reasonable thing to do if you can't put a peripheral stent in there.
Great comments. And now I'm going to invite Dr. Raj Chandwaney to present on just marker technique via an occluded SVG to solve complex CTO.
Good morning. It's an honor for me to share this case with you all here today. This was about a 2.5 hour CTO case, so I'm going to do my best to condense this to 5 minutes. I'm not usually a fast talker, but I'll do my best here. I don't have any financial disclosures. This is a 75-year-old gentleman who was referred to me by a colleague in my community. He'd been experiencing progressively worsening shortness of breath, which was always thought to be his angina equivalent. His initial workup led to an echo that showed his ejection fraction had dropped from 47% down to 30 to 35%. His workup led to a cardiac catheterization that suggested left main and right coronary CTOs, a patent limit LAD, chronically occluded vein graft to RCA, chronically occluded vein graft to diagonal, and a critically stenosed vein graft to an obtuse marginal. Because of the degenerated appearance of the vein graft, the referring doctor did not believe that the vein graft was salvageable, so he was referred to me to consider CTO PCI of the native vessel. Although the diagnostic cath was performed in October of 23, about 2 weeks thereafter, he was diagnosed with subsegmental pulmonary emboli, and the patient was advised to complete 3 months of uninterrupted anticoagulation before going any additional invasive procedures that would interrupt his anticoagulation. I met him about a month or two after in the office, after the diagnostic procedure, and we performed a cardiac MRI in the meantime, which showed that the right coronary artery was non-viable, but all other territories of the heart are viable. The ejection fraction was 32% on that. He's on reasonable medications, except that he's allergic to statins. His bypass surgery was back in 2004. Exam was unremarkable. These are a few pictures from the referring doctor's angiogram. This is the right coronary artery CTO, which, as mentioned, was non-viable by MRI. This is the left coronary injection. This is the old occluded vein graft to a diagonal artery, which has been known to be occluded for many years. This is the stump of the vein graft to the right coronary artery. This is the vein graft to the obtuse marginal, which has a critical osteal stenosis. And again, the referring doctor didn't even try to fix it. He just thought this wasn't salvageable. This is the lima to the LAD. Here's a couple of representative images of the cardiac MRI. This is a two-chamber view. The calculated ejection fraction was 32%. This was a sample image of the delayed contrast imaging, which was read out as a non-viable right coronary artery. So when I brought the patient back for the intervention about 3 to 4 months after the initial procedure, this is what the left main coronary artery looked like. And for better or for worse, this is what the vein graft to the obtuse marginal now looked like. And because of the uncertain anatomy, working with an antegrade approach, I decided this was a primary retrograde case, and my only real good, well, not good, but my only retrograde option was to use the old occluded vein graft to that obtuse marginal as my retrograde channel. So I did this by penetrating the proximal cap of the vein graft using a warrior wire, which I initially advanced about 1 centimeter into the graft. I chased that with a Turnpike LP microcatheter, and then worked down to a Mongo wire, which I was able to drill all the way through the body of the graft towards the obtuse marginal. I then tried to chase that with my Turnpike LP microcatheter. I could spin it to this location here, but could not spin it any further despite significant amount of time and aggressive spinning of the catheter. I then took out the Turnpike LP microcatheter and just did a balloon inflation with a 2030 balloon as far as I could push it. And then I switched out to a Mamba Flex microcatheter, which I was able to spin around that turn and down the body of the graft towards the target vessel. I then took out my Mongo wire and formed a selective angiogram through my microcatheter to better understand the distal anatomy. I then reinserted my Mongo wire, but directed it up towards the distal cap of the occlusion in that obtuse marginal, and then performed this angiogram to better understand my anatomy. I tried to cross retrograde, but probably because of the angle in the graft itself and the second angle where the graft attaches to the obtuse margin, I just didn't have enough backup to cross retrograde. So then I just switched to an antegrade technique using my warrior wire and aiming it towards my retrograde Mongo wire. Once I got wire overlap, I chased that with a Turnpike spiral microcatheter, and after that crossed the body of the CTO, I was able to switch out for a workhorse Xi'an blue wire, which you see here going down the obtuse marginal. Angioplasty and stenting was then performed using standard techniques, and we got a good final result. In conclusion, the patient was discharged the following day without complication, continued to report resolution of his angina equivalent symptoms at 3 months. We did a follow-up echo about 3 months to decide if he needs a defibrillator, but his EF actually came up to 50%. In conclusion, old occluded vein grafts can sometimes be used as a retrograde channel to solve complex CTO cases. A retrograde wire position just beyond the distal cap of a CTO can sometimes be used to facilitate antegrade wiring using the just marker technique. Thanks.
A great case. So, there's sometimes risk of ballooning these degenerated vein grafts, of embolizing and so forth. Do you think it would have just been easier to first try the antegrade approach on the left main and see where the wire goes, or?
I didn't feel comfortable with that without having visualization. Even if the wire went somewhere, I never like to chase a wire with a microcatheter until I know where that wire is. So I personally would have felt uncomfortable. And in my experience, this was the best approach. But I think there's always lots of ways to do these cases.
Congratulations. This is actually a very good demonstration for operators in the room here to utilize SVGs as a good way to visualize the distal vessel in the CTO segment. I think the message here is when we see degenerated vein grafts, it's probably better to refer quickly to a CTO colleague where there's still good visualization and you could inject it, rather than trying to stent it and temporize. And in my center, what we usually do is as soon as we identify something like that, we refer to the CTO operator at the same sitting or maybe, same admission to do the CTO right away.
I think that's a great comment. I mean, I would say sometimes even I, as the operator, gets into a situation where I've got an unstable MI patient, and even though I have CTO skills in those situations, I still tend to, for the time being, salvage the graft just to stabilize the emergency, because I think working on the CTO would just take too long, but those are always the toughest situations.
Yeah, that's a great case. Congratulations. The other thing that, that you can do is, since you were able to go through the vein graft, is, and it has been used a lot overseas, we don't do that much, you can balloon a little bit the vein graft since the patient was already on anticoagulation, and leave the patient for some weeks of oral anticoagulation. And sometimes our guys in Italy have proven that this may be enough to open the vein graft on its own. I don't know if any of you has followed that approach.
That vein graft was pretty degenerated, so I don't think it was long for the world, regardless, but yeah, maybe.
In all honesty, I think in these situations, I guess I'm biased because I'm married to a very aggressive CTO operator, Stefan Rinfret. He says that these type of grafts are only destined to be coiled, and CTO is destined to be open, so.
I do think one point is, I think we underplay the just marker technique, because Dr. Prasad, as you were saying, I think to go blind and just take a aggressive wire down that left main to the circ without having the just marker there is, you know, you're going to have complications that way for sure. But with that just marker, it gave you a lot of confidence to take these aggressive wires, knowing it's just right next to the wire. And so I think that that technique is incredibly useful if you want to really escalate the AWE to these very aggressive wires. Now, you got across with not such an aggressive wire, but you could have used more aggressive wires because you just had that just marker there. So I think that was a great technique.
Yeah, I used a Warrior, which is equivalent to a Confiance or Pro 12. Yeah.
And I would also, those, you know, crossing those vein grafts are pretty safe. I mean, those are thrombotic. They typically, with that little balloon inflation, they're not going to misbehave, and you typically don't send emboli distally either. So I think vein grafts are a very viable option for especially that just marker technique.
Thank you.
All right, thank you. So our Dr. Bruner is presenting our next case, pumping the brakes, careful consideration when accelerating mechanical support.
Good morning. Thank you for having me. We'll get started. I have no disclosures, and we'll get into the case. We have a 41-year-old female who is in an outside hospital, intubated with bilateral pneumonia, flu A positive with superimposed MRSA, who presented as a transfer with worsening respiratory status and septic shock. She had no known cardiovascular disease, but had risk factors with hypertension, type 2 diabetes, tobacco, and substance use. The information that we had was that an echo performed in an outside facility had mildly reduced ejection fraction, but was limited secondary to the patient's tachycardia. She was found in respiratory distress at a hotel, intubated in the field, and in addition to her pneumonia, also had suspected pyelonephritis, underwent a BAL that was sent for cultures and a left-sided thoracentesis, and then arrived at our facility, intubated, sedated, on 2 pressors with a blood pressure of 90/33. For her initial labs, she had an elevated lactate that was uptrending, elevated transaminases, non-significant troponin, and elevated NT-proBNP, significantly elevated procalcitonin, and she was acidotic. Presenting EKG, just sinus tachycardia with some nonspecific changes in V3 through V6. Initial echo had a globally reduced EF, probably in the 20 and 25 area. And then what I didn't have on here was that the RV free wall was noted to be hypokinetic as well. And so septic shock, but in the setting of her decreased ejection fraction, we were asked to perform a right heart catheterization. And then since her EF was low, we wanted to rule out CAD as a cause. So for her right, she had elevated filling pressures, but essentially preserved cardiac output and index. And then we get to her initial angiogram. And so the right had some high-grade sequential stenosis there in the proximal and the mid portion. Left. Oh, get back. There we go. Left had what we believed to be a CTO there in the mid portion of her LAD, filled by left-to-left collaterals, and then some disease in a OM as well. And so we had discussions at that time with the CT surgery team, and unfortunately, because of her targets and she was hemodynamically unstable, they felt like she wasn't a candidate for bypass. And as we were deciding and obtained labs throughout the catheterization and had a discussion about advancing support, patient had worsening respiratory failure, worsening acidosis with lactates being sustained greater than 11, despite being managed on a bicarb drip and with ventilator support. And she also had worsening renal function. We had lack of data in patients with refractory elevated lactates, but given her age and her oxygenation issues, we elected to go with mechanical support and proceeded with VV ECMO with a Protect Duo and then an axillary 5.5 prior to intervention of the RCA. And the determination to intervene on our RCA was to give her the best chance of the recovery because it was the only vessel we felt was amenable to intervention. And so we've now progressed, the impella in place. And so the post-fix is actually showing first. We used IVUS in order to image for her sequential stenosis and found that at least 2 of the areas had deep calcium, and she underwent lithotripsy with shockwave. Unfortunately, that was complicated by VFib arrest while we were doing the shockwave, requiring multiple shocks or defibrillations, but then felt like we had a good angiographic result. Unfortunately, she was unable to be weaned off pressors, and then throughout the course of her, the next 24 hours, had worsening acidosis with lactic acid. She was placed on CRRT within the ECMO circuit, but despite all the support, she had worsening clinical status, and the family decided to withdraw care, and she passed shortly after discontinuation of support. And so our key point was we had careful consideration and discussions between multidisciplinary team as to how to accelerate mechanical support options when evaluating patients like this. Thank you.
So unfortunate case, I think very challenging when you have both cardiac and basically septic situation. You know, I probably would have thought about VA ECMO instead of VV ECMO. Is that something that you guys talked about?
It was a discussion that was had. Given that her persistent issue had been hypoxemia despite the ventilator, the decision was made to go through VV. But yes, there was a discussion landed on that.
Yeah, I mirrored the same. I think if you had started with the VA ECMO from the get-go, you would have had more support to actually perform even complete revascularization, which would have given her best chance. What I think was also interesting is the infection and whether there was a component of myocarditis that had also played a role in this picture of cardiogenic shock.
Yes, ma'am.
I can't help but wonder if any of that stuff that you did made any difference at all. You know, when you have a patient like that with that type of presentation, and we know there's cardiomyopathy with sepsis, and you wonder if that was an innocent bystander RCA that had been there for years. We get sucked into these cases all the time to participate and provide support and do these things. Obviously, the contrast is not good for kidneys that are already But so that to me is a case where when I saw you pumping the brakes, I wonder if we don't pump the brakes earlier than that. But it's hard for us because we can't say for sure that that's not part of the problem, but I can't help but think about that in cases like that.
Yes, sir.
I think that's a great point. I mean, it counts as a PCI mortality even if they die of sepsis, so, you know, we have to be careful.
Yeah, I would echo those points as well. I sometimes help administer a hospital's ECMO program, and the outcomes of patients with septic, hemodynamic collapse, and ECMO of all sorts are particularly grim. And I was actually struck by early in your presentation, you noted this patient didn't have much of a troponin elevation. That does mean something. Our troponins are very sensitive. You can have really profound LV dysfunction in the setting of sepsis, even with coronary disease. It doesn't mean their coronaries are causing the issue.
And the lactic acid is a very, very strong predictor of outcomes. So throughout the case, the lactic kept increasing. So it was showing from the beginning it was not going the right direction.
Thank you. Thank you.
And now I'm going to invite Dr. Mohamed Alam to present the first step may lead to catastrophe.
Thank you so much. It was a great pleasure to present a case at this usually elegant meeting. I am Mohamed Alam from Egypt, from National Heart Institute, and our case was entitled, "The First Step May Lead to Catastrophe." Excuse me. Our case was a male patient, 65 years old, heavy smoker, presented to us with retrosternal typical chest pain with no specific ECG changes and positive cardiac biomarkers, and he diagnosed as non-STEMI. So we start to perform a coronary angiography via a right femoral approach. One of our colleagues start to insert a sheath in the right femoral artery, but he feels a resistance many times. So he performed an angiography through the needle. It may be subcutaneous or maybe a dissection. So I decided to insert a left femoral sheath and perform immediate contralateral antegrade angiography, which revealed dissection in the right external iliac artery, but actually with good distal flow. Now we decide to perform a coronary angiography at which we have an acute coronary syndrome situation, which shows atherosclerotic right coronary artery, atherosclerotic LCX, TIMI3 flow in LAD with mid-segment tight thrombotic lesion, but with TIMI3 flow. And at this point, we stop and to perform a plan. We have a tight mid-LAD lesion, but with TIMI3 flow, and a dissection in the right external iliac artery, but with good distal flow. How can we manage this situation? When we're thinking about the plan, the patient developed severe agonizing right lower limb pain with acute motor loss, and he started to develop a vasovagal attack and about to be shocked. So we perform an angiography for second time, which revealed total external iliac artery. Now, it was a clinical challenge. We had an emergency total right external iliac artery and no available peripheral intervention equipment. So we form a rapid decision. We pass a coronary guide wire via a right Judkin guiding catheter and with a big NC balloon to restore the flow in the right lower limb arteries. And this is the result. We restore the flow in the right lower limb arteries, but still have a dissection in the right external iliac artery with a rapid recoil. Now, we still had ongoing right lower limb pain and still had a dissection and still had no peripheral intervention equipment. How can we manage? We implant a coronary stent 5.26. We are sure that it will actually not oppose to the vessel wall. We pass a second guide wire from inside the stent, and with multiple simultaneous inflations of the two big NC balloons for many times and at many levels. And this is the final result. We restore a good flow in the right lower limb arteries, and now we get an intact pulsation and perform simply a PCI to LAD with a long stent and NC balloons, and get a final result. The patient transferred to CCU without chest pain or lower limb pain, and with intact distal pulsation and immediate lower limb duplex revealed normal arterial flow in the right lower limb arteries, and the patient refuses any further intervention to perform an IVAS at the second day or any further intervention. So we perform first and third months later CT angiography was done, which revealed patent well-deployed stent in the right external iliac artery with normal distal flow and an atherosclerotic and external iliac artery. Our take-home messages: any simple maneuver must be done carefully, and primary PCI requires a careful management to the patient, but with rapid decisions and flexibility with decisions, and the plans must be present to get solutions for different situations. And thank you.
So another impressive case from Egypt. You guys are very, resourceful. That's awesome. So, what were the balloon sizes that you inflated inside that stent? How big?
4.0
So
and
4.0 to
4.5.
nominal. So probably 4 and 4.
Multiple levels and multiple pressures.
I mean, it looked angiographically awesome. It looks great.
I think one message here for everyone, that ultrasound-guided access is a very important part of our routine now, and it should be performed at any point you have the equipment available.
Congratulations, excellent case. It was a great demonstration.
Thank you so much.
And again, no injection through the needle too. That's the other point.
Or radial access.
There may have been a lesion there, the location it's at, and I couldn't quite tell, but it didn't look like the entire iliac was dissected. It was just a segment, right, that was dissected. It looked kind of focal, so it makes me wonder if there was a plaque or something that the J-wire got under.
J-wire, from the J-wire.
Yeah,
maybe. I think from the J-wire.
And most of those dissections, if they're not flow limiting, they heal up because they're retrograde, wire dissections, the flow is antegrade. So a lot of times, if it's a small dissection, you leave it alone. Or if you can get a sheath up past it, do your PCI, and then on the way down, pull a long sheath down and deploy a stent. So.
Yeah, I think great case, and welcome from Egypt again. And I think you really show us that necessity is the mother of invention. So good thinking on your feet. But I think my colleagues have pointed out again, use of ultrasound-guided access for the femoral is important, and try not to inject through the needle as well. But we really liked how you went contralateral right away and diagnosed what the issue was and then got that taken care of.
Okay, thank you so much.
And also the case in point of you can dilate a coronary stent to 8.0 and maintain the radial strength. You probably, if you did a cine of that, you'd see some disarticulations of some of the crossbars. But again, the stent, and 3 months out, looks great. So kudos.
And it's drug-eluting, so it's a bonus. Thank you.
Thank you so much.
I think our last case is left main involvement. Will you get involved? By Dr. Agamy.
Good morning. Thank you for having me today. My name is Salaheldin from Royal Free Hospital in London. No disclosures. My case today is a 53-year-old lady who presents with chest pain, anterior STEMI, and mild left ventricular systolic dysfunction with anterior hypokinesia, with a background of a smoker, heavy smoker, uncontrolled dyslipidemia, hypertension, and physical inactivity. That's the angiogram. The cranial view showed classic LED mid-total occlusion, and the caudal view as well. RCA was normal, but the patient was very agitated throughout the whole procedure. And then we pre-dilated with 2.5 semi-compliant balloon, and we restored the TIMI-3 flow, and we are about to stent by Zion's 2.75, but we noticed that. So we know that the left main is dissected because of the guiding catheter, and the patient was hemodynamically stable, no chest pain, no C changes, a little bit agitated throughout the procedure, but still hemodynamically stable. So we had some time to breathe in and think about left main incident iatrogenic one is 0.07 to 0.1%. Multiple causes, maybe non-coaxial catheters, contrast injection, pressure, bile pressures damping, deep engagement, aggressive maneuvers, and balloon rupture or after balloon angioplasty. Usually we diagnose it with different multi-angiographic views and IFS or OCT. The treatment usually one of three: conservative, rapid stent deployment, and cabbage. So we had some time to breathe in, and then we took another caudal view which showed no dissection. And then we went for an IVUS. So IVUS showed that the bifurcation, and then showed healed dissection with hematoma formation. So what you do next? So the three: conservative, PCI, or urgent cabbage. So after many MDT between three consultants in the cath lab together, and then we went through PCI with left main. After, of course, we destented the mid-LED with a synergy stent, with a Zine stent, and then we stented 4, 5, 20 drug-eluting stent. And that's the post-stent. And that's the IVUS post-PCI. The patient was hemodynamically stable, stayed for 3 days after the procedure, and discharged on DAPT. And then we brought her back in 4 weeks. She was asymptomatic, completely asymptomatic, and for angiogram, and that's the angiogram, check angiogram after 1 month. And the wire inside, because we did an IVUS, which showed the same results as the last IVUS post-PCI. And that's the caudal view as well. So my take-home message is that the primary PCI to mid-LED iatrogenic left main dissection was concealed dissection with a thrombus formation in the coronary angiogram and the IVUS. There is no sufficient evidence data to treat or to leave the concealed hematoma or concealed dissection in the left main, but excellent short-term follow-up angiogram and clinical outcomes. And question for you, would you have done anything differently? Thank you.
So the challenge with sending these people for cabbage is what can the surgeons do, right? So what are we asking them to do? Open up the left main and endarterectomy, repair? If they put a lima on that LAD, it probably won't take because there's too much antegrade flow. So it's a tricky situation. I think PCI is the right answer. I don't know who would feel comfortable just watching them, but I don't know if cabbage is really an option.
I agree. I think you're in a terrible place with a cabbage because if you put grafts on and that thing heals, your grafts are going to go down as well. I think what really struck me about that case is what an amazing example of the utility of orthogonal views that was. In your cranial view, your dissection is up here, and you could see it beautifully. And then when you looked
Nothing.
from above, it was there, but you just couldn't see it. So I would dispute that it was hidden. You just needed to see it in that eleocranial view to see it, because it can totally hide if you're not taking orthogonal
Yeah, I agree. I personally would have stented too. Just what I would have done differently is I probably would have not injected once I've identified it, because that could extend it. I would have probably put a wire into the circ because I didn't know the extension and the position, and you don't want to lose it. And maybe I would have stented that circ there as well, because there was a bit of lesion in the circ, but also in the mid-LAD on your control angiogram looked like there was some residual disease.
Yeah, we brought this lady back after 6 months to do the mid-LAD, yeah.
Sorry, I got to make a comment too. You know, in your history, you took the trouble to talk about how the patient was agitated. And I do think that, you know, and we've all been in those situations where the patient's combative and it makes the procedure overwhelmingly more difficult. And, you know, in terms of the etiology of your left main dissection, maybe it was because the patient was moving around and, you know, the guide. And so I would encourage us all to take control of those situations. If a patient is not able to participate in the procedure, you need to take control of that and call anesthesia and intubate the guy and paralyze him. Because I do think you put that in there probably because you thought that might have contributed, right? Yeah. And so for patients like that, a job that's incredibly, you know, can be difficult. To have a patient not cooperative is not good for the team. So just consider that.
And you're fortunate this happened during PCI. We've all, I'm sure, on this stage have had, in the audience, the diagnostic cath that dissects the artery, and then it's like even worse.
But no way I leave that alone. I got to go to sleep at night.
Exactly.
And you're like it happened after you had the wire in the LAD.
Exactly.
So you had all the luxury to.
Yeah, the IVAS showed concealed one, but we didn't feel comfortable to leave it. Thank you.
Thank you.
Case and welcome from England.
So that closes our session. Thank you, everybody, for attending.